Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm back in London again at the Royal College of Anaesthetists for the Centre of Perioperative Care's Perioperative Leads Day. We've had a fantastic day. It's been really busy, 60-70 people here despite London train strikes and all sorts of other travel chaos. Really good turnout. Lots of exciting speakers, lots of exciting topics. And some of the most interesting bits for me have been sort of the talk about policy and policy transformation, because I have to say that's not my strength. So I'm really looking forward to hearing from our excellent guests now. They're going to tell us about how this is going to go into the future. So if I could ask James, Simon and Denny just to introduce yourselves to us.
Great, yeah, thank you very much. My name's James White. I'm the clinical lead for Anaesthetics and Perioperative Medicine in Cheshire and Merseyside ICB. I'm an anaesthetist and previously qualified as a GP.
And I'm Simon Rang. I'm one of the anaesthetic consultants in East Kent, and I also have a lead role within the trust and also in the South East region as regional lead for perioperative medicine.
And I'm Denny Levett. I am the incoming director for the Centre of Perioperative Care. And in this context, I have been a part of the regional network for perioperative medicine leads in Hampshire, Isle of Wight.
Fantastic. So I guess to get us started then, bearing in mind, although we're primarily UK focused, some of our listeners will be listening from America, Australia, wherever. And when we're talking about policy and policy transformation within the UK and regions and networks, and what do we mean by regions, networks, and how are we sort of dividing these areas up?
Well, particularly in the current context, that's a very movable feast. But as essentially one of the advantages of the health system in the UK with the National Health Service and a unified system is that we provide all care from community-based to hospital-based care. How networks have been set up and regions have been defined have evolved over time, and they are quite changing. But what we have been with is the situation where you have the Department of Health, which sets policy and government policy, and then there has been NHS England, which is an arm's length body that has then organised regional care and delivery. And those things have been, as we know, NHS England is changing, but will not be continuing beyond 2027. But what we have set up and which we will continue with is regional networks in subspecialties to try and improve the integration of care across those networks. And also that the way the funding has been delivered has moved in the last 5 to 10 years from individual trusts or hospitals having funding to trying to allocate it to a region. And James will tell us more about integrated care boards, but they oversee the delivery of care across primary secondary care in that region. And myself and Simon have been involved in a perioperative network because what became very clear after COVID in particular, but increasing over the last 10 years, is that the surgery is a small part in the perioperative pathway, and we need better integrated care in the build-up and preparation for surgery and recovery from that spans primary and secondary care. And with us all working in silos, it was very difficult to move forward. So now we've tried to integrate across regions.
We've been very fortunate in that we've had a very good national clinical leadership in perioperative medicine. And perioperative medicine is a specialty that's only really been born over the last few years, and with a recognition, as Denny said, that integrated care throughout the perioperative period is really important and improves outcomes after surgery. NHS England and the national clinical leadership by Ramani Moonsinger was really fundamental to creating a clear national strategy that we were then able to roll out across different regions and ICBs, so that almost kind of localising a national policy and a national strategy, creating really important networks across regions and across local integrated care boards to as I say, localise that national strategy, which has worked really well actually.
And I think we use regions and ICBs, integrated care boards, those terms quite a lot. But again, just to really hammer home that point, James, can you maybe explain the difference between what an ICB is to a region in geographical terms?
Yeah, of course. So my ICB, or Integrated Care Board, is Cheshire and Merseyside. So it's a geographical footprint. And within that footprint, there is population. I think ours is about 2.7 million people. And the ICB is an organisation which is responsible for delivery of care to that population through both primary and secondary care. So GP surgeries in the community, primary care, and secondary care being at the hospital trusts. Because the ICBs span primary and secondary care, they lend themselves very well to the concept of perioperative medicine, which of course begins in primary care, continues into secondary care, and then of course returns to primary care when the patient has had their procedure. So the advent of ICBs, unfortunately, was somewhat overshadowed by COVID. But now that hopefully that is in the past, they are a good framework in which to be able to look to really try and deliver on perioperative medicine. So you also mentioned the term regions. So to give some real world context, my ICB is one of 3 in the Northwest region, the others being Lancashire and South Cumbria and Greater Manchester, which are simpler systems than ours. Ours is one of those complex in that I think we have 9 acute provider trusts, some tertiary trusts, and a few hundred GP practices as well. So it is one of the more complex systems.
We're really fortunate here to have ICB and regional network representation within a perioperative space. I mean, it's different areas, but how do you find that working relationship between the ICBs, regional networks, and how's that helping deliver policy on the ground, if you like?
It's really helpful because we are essentially at each level, we are able to create networks of like-minded individuals who all have the same problems on their plate, if you like. So we have a regional leads forum, predominantly a WhatsApp group, and we kind of communicate through there sometimes, and we can share problems that are at kind of regional level. And increasingly, we also have ICB networks, and the ICB networks include individual trust representation as well. So it's almost like a pyramid, and the creation of clinical nurse, so medical, nursing and operational networks at each of those levels, all trying to kind of work towards the same hard national strategy, is a fundamental change, as Denny said at the beginning, in the way that we're organising our work. We are now all streamlined into achieving a certain kind of high level goals and objectives, but as I said before, they're localized to individual areas. We have slightly different ways of solving similar problems.
I have found working as an ICB clinical lead, having a regional lead, very helpful because it's allowed us to coordinate with the other 2 ICBs in our region. Although we are separate systems, obviously we're in the same region of the country overall, and therefore we do have similar challenges with the similar levels of population deprivation, for example. So I think it is very useful. I also think that the national team setting out what they called 5 core requirements previously was incredibly helpful, because that's allowed us as the 3 ICBs in our region, but then also my ICB, to organise our work streams in a logical way, which hopefully helps to encourage clinical engagement and for people to feel empowered to deliver on those.
Can you give us some idea of what those core requirements are and how they're feeding into your practice?
Yeah, so the first one is about early perioperative screening of patients, as early as possible in the pathway, really, to be able to identify risk factors for a poor outcome. And of course, then to be able to intervene with those risk factors. And that leads into I think it is the second of the requirements actually, which is to encourage proactive support for patients who have either chronic diseases which need to be optimized or risk factors for a bad outcome, which could respond to prehabilitation. I believe the third one is to do with regular contact for patients who are waiting for surgery. There's a recognition that patients can become worse. They can become more unwell, more frail while they're waiting for surgery. And so the concept of waiting well, making sure people's health doesn't slip while they're waiting for their treatment is also really important. And in our ICB, we have some initiatives to try and address that. The fourth of the requirements, I believe, is relating to trusts only listing patients for surgery when they are deemed medically fit. So that is something for trusts really to try and deliver through their own strategies, but we want to support them with that. And the fifth one is empowering patients and ensuring that we're engaging in shared decision making. conversations so that we're actually doing the right thing by patients. There's published evidence that a sizable percentage of patients actually regret having surgery when they've had it. So we haven't done the right thing by the patient in those situations. And we, of course, won't have done the right thing by our health system either. So it's really important to make sure those conversations are had so that we're using our resources appropriately and also we're, as I say, doing the right thing for patients.
There's a requirement for optimization of medical conditions. So we are, within our ICB, are using perioperative tools to identify patients who need exercise prehabilitation. And there's two ways of doing that. You can do kind of quite intensive supervised exercise using cardiopulmonary exercise testing, or the other kind of side of that is to engage people in simple community-based lifestyle services. And we are actually working with our community-based lifestyle advisors to signpost patients who are on our waiting list to those community providers and are encouraging them to call patients on our waiting list to try and get them to engage in the services prior to their operation, accepting the fact that this might be a teachable moment for the patients, and in fact they might be more motivated to do that kind of thing while they're waiting for surgery. So, and that's using ICB resources, sharing ICB resources for that would previously have just been being done anyway in the community, but targeting populations of people who are actually waiting for surgery. So it's that joined up care.
View then, how does that go from a national CPOC visionary level through to a regional ICB level down to a trust?
Yeah, good question. As Simon said, it's been helpful in perioperative care after the reset after COVID. Within what started as the elective recovery plan, have a very clear vision for what good perioperative care looks like. And I think that was, fortunate things. CPOC had come to pass. Perioperative medicine had got to that level of evolution that it was no longer a niche area and people were beginning to believe it's actually a really core part of what we do, combined with a patient population that are getting older, frailer, more comorbid, and particularly immediately post-COVID, the impact of very little physical activity and social isolation. So I think those things came together, and the elective recovery plan and the priorities that James has alluded to the 5 pillars of care that CPOC was set up to deliver. The really nice thing in this space is we appear to have a specialty that prioritises 5 pillars of care that have been put into national strategy within elective recovery plans. And at the same time, we have fortuitously rearranged the funding of care to actually support care, as James alluded to, that spans primary and secondary care. How CPOC, I think, can help, particularly, is that although there are many of us who are early adopters, and the 3 of us here who are very passionate about this and are in regions that have made great steps forward. And I think what is really helpful is that we are all saying the same thing. Number one, I think consistent resource and guidance, so that I think CPOC, by the generation of clinical guidance that is, rather than just being the niche in-hospital bit, spans the pathway and engages not just doctors, but the allied health professional and the community resource. So I think that's how we work together. Many of the CPOC leads are actually NHS England leads. And I think the relationship with ICBs varies across the piece. And also, I don't know if you've found this, James, but some ICBs, we didn't all start at the same time. And so Manchester, for example, is a very mature ICB, and I think people have worked out how to work well together. Hampshire, Isle of Wight, reasonably recent. We only came into being 2023 or 2024, so we're still, I think ways of working together move. But I think having the structure of CPOC, having this guidance, which is all trusts should be doing digital screening, for example, has really helped. And I think it's really key that we work together. And it's actually one of my observations that although many of us in the NHS England regional network are supporters of CPOC, sometimes, I don't think we're fully utilising that relationship. And I would say the same with GIRFT, which is obviously the QI national project.
Just getting it right first time for people that may not be in the UK. But
getting it right first time at GIRFT, about trying to remove unwarranted variation in care. So differences in care and outcomes that are not determined by differences in patients. They're determined by, often other things that we should address. But I think, this is a real opportunity, for GERFT, the regional networks, ICBs, all to work together, because, we can feed down to them what we think good care looks like, but they can feed back to us. What are the barriers? How come, what is it that's not allowing you to do that right now? A lot of them appear to be financial, but they're not purely. Sometimes it's not, looking at what good practice looks like in other regions helps people realise how you can reorganise care. And it's also getting the will, because you need to bring the whole of the perioperative team with you.
And it's interesting because looking at from a regional perspective, Denny's point about the fact that different ICBs are at different levels of maturity is actually massively obvious. And you can see that some ICBs are working really well, and they embrace the concept of perioperative medicine. They have QI project managers that are involved in organising the networks and making sure that network meetings happen regularly. And you have other ICBs that have no insight into perioperative medicine whatsoever. So James's ICB is really mature. James is massively involved. He knows a lot about the language that we use, whereas I could name several others that have really no concept at ICB level of perioperative medicine, and therefore the trusts are working almost entirely in silos. And that's, from a regional perspective, that's our challenge, to try and disseminate that good ICB practice, if you like, and share that to ICBs that are slightly struggling.
Yeah, so you mentioned regarding our ICB and the maturity. Yeah, it's certainly not a brand new ICB. It's probably not one of the most mature either. I think I've been in post for about 2 years now, working on developing the perioperative medicine agenda in our ICB. And I think we touched on potential barriers to implementing.
Yeah.
And certainly it's true to say financial is one of them, definitely.
Yeah.
There's no getting around that. But what's really useful about the regional leadership and the leadership from CPOC is having resources that are readily available that we can deliver. And it's possible to spread the message that change doesn't have to necessarily require new capital spend. A lot of work has already been done. A lot of resources are available. It's just getting them out there to the right people and empowering those people to then deliver those to patients.
And CPOC is rich with real resources that you can use to implement this strategy. And that's always the hardest thing. Even mainly right down at trust level, if you've got a clear strategy that's being shown to you, when you're trying to lead that change and implement that change in individual organisations, it's always extremely difficult for a whole load of reasons, some of which are financial, some of which are cultural, some of which are just the fact that the trusts are really trying to work really hard, and to take on the risk of change is quite difficult. And if we have national resources that are available to kind of implement at the ground level, then that is a really helpful thing to have. So CPOC and GERFT and NHS England all working together is definitely the way forward.
Brilliant. On that note, I'm afraid we're out of time, but James needs to run off to his session. So thank you all for your time. Thank you all for coming to Top Med Talk. As always, you can hear us online on our website, through social media. It makes a really big difference to us. And thank you very much again to our sponsors, which are BD and GE this year, for keeping us free and open access to the world. And thank you, Denny, Simon and James, for coming to join us.
Thank you.
Top Med Talk.
Top Med Talk is the broadcasting arm of EDPOM, Evidence-Based Perioperative Medicine. Join clinicians from around the world at EDPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.